Okay, so it's a little past the hour, and I think we'll get started. I'd like to welcome everyone to the latest installment of the NYGA webinar series. My name is Steve Namagon, and I'm a gastroenterologist here at New York Gastroenterology Associates. We are a premier private GI practice based in New York City with offices in Manhattan and Brooklyn. Our group includes 16 gastroenterologists, as well as nutritionists, physician assistants, nurses, and other talented support staff. We provide consultative services and a variety of procedures for a wide range of GI conditions. Today, I have the pleasure of introducing one of the stars of NYGA, Dr. Anna Tuyama. Dr. Tuyama has an impressive resume. After earning her medical degree in Brazil, she came to New York City, where she did her medical training and her GI training at the prestigious Mount Sinai School of Medicine, Mount Sinai Hospital. She then gained a decade of experience at several top-tier practices before we were lucky enough to bring her over to NYGA. Today, Dr. Tuyama will discuss an issue we all come to grapple with at one time or another: diarrhea. Before I turn it over to Dr. Tuyama, a few housekeeping details. This webinar is being recorded and will be available on our website along with other previous NYGA webinars. Please use the Q&A function to ask any questions, and we will try to answer as many of them as we can during the talk and after the talk during the Q&A session with Dr. Tuyama. And finally, while we cannot dispense medical advice in this forum, we can answer questions for educational purposes. And now, without further ado, I will turn it over to Dr. Anna Tuyama.
Thank you, Steve. It's my pleasure to be here tonight and presenting this webinar with the title of diarrhea, getting to the bottom of it. So let's get started. Before I get started, I have no conflicts of interest to report. I would like to thank Dr. Namagon for moderating this and Dr. Hiroko for helping me, helping organize this webinar series and even helping me figure out that the audio is actually working right now. So let's get started. So today, in today's webinar, I will try to cover most issues related to diarrhea. We'll be going over the definition of what diarrhea is and how it presents. I will also be talking about, things that you can do on your own to get better and how to prevent more serious complications from diarrhea. We'll talk about when to seek medical evaluation and especially when to consult with a gastroenterologist. And then I'll go over the workup and the sequence of diagnostic tests that I needed to reach a diagnosis. And also some of the causes of acute and chronic diarrhea and its treatment. And most importantly, how to prevent diarrhea, okay? So to get started and just to give a perspective of the scope of the problem, diarrhea is extremely common. About 47.8 million cases occur in the US every year. That means that 1 in every 6 Americans will get diarrhea in any given year. And some people will get diarrhea more than once in a year. It's one of the top 10 leading causes of death in the world, especially in children and older adults. Diarrhea is a very common reason for hospital visits and obviously office visits, especially to gastroenterology practices. It's a lot, and it ranges in. It presents in a very broad spectrum, from it can be a very serious and deadly disease to a nuisance problem in healthy adults. And for us doctors, because it's such a broad differential, and there are so many diseases and problems that can lead to diarrhea, it can pose at times like a diagnostic and therapeutic challenge to doctors. All right. So diarrhea is essentially defined by a change in the number and most importantly in the consistency of stools from any person's normal. So you'll find a different definitions, but the most important is that any deviation in the stool consistency from normal is considered diarrhea. And then in the famous like Bristol stool chart, anything between types 5 to 7 is considered diarrhea. So from like soft broken stools to mushy stools, and then liquid is considered diarrhea. Now, in order to understand the mechanisms like in our bodies that promotes diarrhea, it is important to understand like or be familiar with the movement of like fluids in the GI tract. So the GI tract is vital in maintaining the fluid balance in our bodies. So in general, like we consume like liquids in the form of like drinking water, juices, but also in food. But the GI tract also in our GI tract, in different segments of the gastrointestinal tract, there are digestive juices are secreted, which helps us digest food. And a big part of like this fluid travels down the intestines where most of it will be reabsorbed. And what comes out is actually a minimal amount of fluid from what we consume and produce. So any deviation from this normalcy, like from this normal state, can lead to diarrhea, which leads me to the next slide. So essentially anything that will promote more liquid in the bowels, like more fluid, will lead eventually to diarrhea. And whether it's like having substances that are not absorbed or digested and they will drag water into the intestines, or whether like there's some toxin or defects in the channels that pump electrolytes and water into the intestines, like causing more to be secreted inside the intestines, leading to diarrhea. Or when you have inflammation in the intestines, like in colitis, where there is disruption in pretty much everything, but most importantly, the ability to absorb the fluid, the liquids from the intestinal lumen, as well as increased motility. Like if the intestinal contents are traveling faster through the lumen, there's not enough time for water to be absorbed and eventually resulting in diarrhea. So most of the time, most causes of diarrhea are like a consequence of more than one mechanism at any given time. All right, so what are the symptoms of diarrhea? And I think most people are familiar with that. One, like I've mentioned, by definition, a decrease in stool form or consistency. Sometimes often associated with increased frequency, like over trips to the bathroom, associated with abdominal pains, bloating, cramping, sometimes with nausea, vomiting, and the urge to go to the bathroom, like fecal urgency. One symptom that often comes to our attention is fecal incontinence, where you have leakage of stools. In general, that it's not diarrhea, but obviously if you have fecal incontinence and you have diarrhea, it will certainly aggravate leakage. But leakage and incontinence it's not necessarily a symptom of like diarrhea. It doesn't translate into diarrhea. Diarrhea obviously can often lead to dehydration, which can be a serious problem, particularly in older patients. And things to watch for when you have diarrhea are thirst or like dry mouth. You have to pay attention to your urine getting darker or like less frequent urination. Your skin can get dry and itchy. You feel your heart pounding faster because you're dehydrated. And headaches can also be a symptom of dehydration. Obviously, as the condition gets more serious, you can go into complete no urine production. to confusion, lethargy, and even what we call like hypotensive shock, where your blood pressure goes down and then you end up in the hospital. So dehydration is a very, very serious problem from diarrhea. Symptoms to watch for that can indicate like a more serious condition are fevers, bloody or oily stools, weight loss, nocturnal diarrhea, which means you get up in the middle of the night to go to the bathroom, more than 6 unformed stools in 24 hours, and severe abdominal pain. And then you've got to watch out for your symptoms and look for help, because like I said, diarrhea can be a very severe condition and lead to serious complications like kidney failure, often from dehydration, heart arrhythmias or heart failure, especially in those who have like underlying heart disease. In some severe infections or inflammatory diseases, bowel perforation, which may result in the need for surgery. An inflammatory condition called SIRS or sepsis, like which leads to hypotension and sometimes multi-organ failure. And some like especially infectious diarrheal illnesses or some inflammatory diarrheas can result in arthritis. And also in acute diarrheal illnesses or chronic diarrhea, you've got to also take into consideration that because of the rapid transit, like sometimes you may not absorb your medications normally, and that can be important in patients taking blood thinners or medications for seizures, okay? Now, leading to what can you do on your own, right? Like, so most diarrhea illnesses like are self-limited, and most patients don't actually need to see a doctor because the symptoms will resolve quickly. But there's a lot of things you can do before you actually either need or to see a doctor or get to see one. The most important is staying hydrated, because one of the most serious complications of diarrhea is dehydration. So, drinking diluted juices or sports drinks like broth and soups, like really anything with like some salt and sugar. None of them are at the same concentration level as the WHO oral rehydration solution. But, often if you can drink juices and sports drinks and eat like saltine crackers, things that have salt or sugar, that will be equivalent like to drinking an oral rehydration solution. But and if you don't have it, or if you can't buy Pedialyte in the pharmacy, you can easily make it at home by mixing sugar, salt, and water. It's actually that simple. In terms of diet, that's something we get asked all the time by patients, obviously, because they want to know what can you eat when you have diarrhea. So, and I'm sure most of you are familiar with the BRAT diet. So most of the time you want to focus on eating starches and cooked cereals with salt. Rice is a great binder. Oats are also good for diarrhea. Bananas, like applesauce, like I said, like toast and saltine crackers and boiled vegetables, and even lean protein. Okay, so that's all okay to eat when you're having diarrhea. And things to avoid, obviously, any fatty foods or heavier, like anything fried or rich in fat will trigger more diarrhea. Caffeine often leads to diarrhea, and dairy, because in most acute in any diarrhea illness, like you have like sort of like a temporary like state of like lactose intolerance. So dairy can often cause more diarrhea. Okay. In terms of medications that you can take, there are a few over-the-counter medications that can be used for diarrhea, and most of them are relatively safe. So like any bismuth products like Pepto-Bismol or Kaopectate, or Imodium like loperamide, try to avoid that in bloody mucousy diarrhea. You probably want to see a doctor if you're seeing mucus and blood in your stools. But it's acceptable to use Imodium like in acute watery diarrheas. And then we will be talking about a little bit of pre and probiotics towards the end of this webinar. Now, considering all of that, when should you see a doctor? Like, let's say, your diarrhea persists. It is important to know that, like I said, it's important to know how to handle the diarrhea symptoms from home, but it's as important to know when you actually need to see a doctor so you can get better soon and avoid potential complications. So, like, pretty much similar to the red flag symptoms, like you should see a doctor in cases of severe dehydration, symptoms that last longer than 7 days, bloody stools, persistent nausea and vomiting, especially if you cannot stay hydrated. You should go to a hospital or an emergency room, with severe abdominal pain and weight loss. And certainly some high-risk groups. So some patients are susceptible to complications, and those include patients older than 70, with underlying heart disease. Like I said, dehydration and diarrhea can lead to heart arrhythmias and heart failure. Patients with diabetes, because you can have either hyperglycemia or hypoglycemia from diarrhea. Chronic kidney disease, because obviously dehydration can lead to further kidney damage and failure and the need for dialysis. Patients on cancer therapy or immunocompromised, in patients with inflammatory bowel disease, pregnant women, or any history of recent hospitalization or antibiotic therapy, which can pose a risk to other infections like C. difficile, which I will mention later in this webinar too. And then any recent travel, like or hiking or consumption of fresh water. There are certain groups as well, that can pose a risk, like to others, especially workers in the food industry where they're handling food. So those also should seek medical attention, to prevent spreading of any potential infections to the community. Healthcare workers, daycare attendees and employees, residents of institutional facilities, so like nursing homes and group homes, all of those need medical advice, to prevent further harm to others. All right, so now shifting gears a little bit, we're gonna talk about how diarrhea is diagnosed, okay? And one of the initial aspects of like a medical consultation is actually going over the history. And I often think that this is like a partnership between patients and doctors where, the more history you give us, like the more you help us make the right tests or the right decisions in terms of your medical care. So keeping a food diary and or ingestion of food history is extremely important, especially in chronic diarrheas, where you have some association of worsening symptoms with consumption of certain foods. A history of prior surgeries, as we're gonna talk about later as well. History of pancreatitis, which can often lead to malabsorption and diarrhea. Any systemic diseases like diabetes or rheumatologic diseases, a travel history. Medications often, as we're going to talk about, can often lead to diarrhea. Contact with anyone sick, or a family history of diarrhea illnesses, and excessive alcohol consumption. Okay. The other aspect that is important, and sometimes patients don't like to do, is to actually look at the stools, because the stool appearance can also tell us a lot about what is going on. So for instance, as black and tarry stools can mean blood in your stools, or an internal bleed. Mucus and blood in the stools can also mean an inflammatory condition, which can be more serious. And in some acute bacterial infections as well can cause mucousy bloody diarrhea. Greasy and oily stools, which often equals or suggest an underlying malabsorption problem, which we see in patients, for instance, with chronic pancreatitis. and changing like the smell of the stool, although that's probably the least predictor of like any specific diagnosis. But again, all of these is like important information that will help us guide through further the need for any testing. In terms of diagnostic tests, like most of the time, especially in acute diarrhea, blood tests or stool tests are not necessary because these are like self-limited conditions. But in specific case, it will help us clarify the etiology or root cause and help us direct therapy. So in terms of blood tests, we often run like a blood count and electrolytes and kidney function to, assess for any complications from like dehydration, for like your fluid status. Hormone tests where we check like for like problems with your thyroid, or like there are some hormone secreting tumors that can lead to diarrhea as well. So this can be very helpful. Inflammatory markers, especially for like inflammatory bowel disease. Again, like when we're in the process of making a diagnosis, or even like following the course of the disease or during flare-ups, they can be very helpful as well. Celiac serologists should determine any underlying gluten allergy or intolerance. So there are a number of blood tests that we can do that can help us reach a diagnosis. In terms of stool tests, like I said, most of the time they are not necessary, especially for acute diarrhea illnesses, but in persistent cases, they can be helpful. Or in more serious, like diarrhea with mucus and blood, it can also guide us on whether or not antibiotic therapy is necessary. Nowadays, there is a pathogen targeted testing, which is DNA based. It's like a PCR test, and which is a faster turnaround, but obviously with limitations, because sometimes a positive test doesn't translate in an active infection or the need for therapy. So it's always important to discuss with your doctor the results, and then obviously testing for C. difficile, which we see in patients that were recently hospitalized or had antibiotic therapy, and test for bacteria, viruses, and parasites. In the stools, we can also test for inflammation. So there are inflammatory markers that are specifically targeted to the stools, which can also be very helpful, and pancreatic enzymes, particularly in patients with chronic pancreatitis and malabsorption and pancreatic insufficiency. Now, in terms of like food-related or food or diet-related diarrhea illnesses, like fasting tests sometimes can be helpful. And often patients come and say, "Oh, yes, I did. I cut out dairy from my diet and the diarrhea went away." So it's almost like self-diagnosed, but they can sometimes be helpful avoiding certain, like when you see a pattern and of like symptoms related to ingestion of certain types of foods. You can always test yourself or do it at home, or even with the help of a doctor, like in terms of avoiding and then reintroducing to see if the symptoms go away or come back. The other type of test that we do for diet-related diarrhea, it's like breath test, where we can test for lactose intolerance, or something called, which is not diet-related, but something that is very popular nowadays, SIBO, which is a small intestinal bacterial overgrowth. And I will touch briefly towards the end of this webinar on SIBO. But the way that they work is that you ingest, for instance, for lactose intolerance, you ingest labeled lactose. And if you digest it well, then the breath test comes back like a flat curve, because but if you don't digest it well and the lactose, like which is the sugar in milk, gets into your intestines, it's degraded by the bacteria in your colon, and then it comes out in your breath as hydrogen, labeled hydrogen in your breath. And then on the graph, we'll see a peak, like which indicates that you did not digest lactose. So that's how we interpret this breath test, So we see a peak on the expired hydrogen, and then it's indicative that you you're not digesting like lactose, for example. In terms of like imaging studies, so it's like a CAT scans or MRs, or CAT like CT enterographies or MR enterographies that are more specific to the small bowel, they can often be helpful and useful in reaching a diagnosis, particularly, indicating any anatomical abnormalities or indicating prior surgeries or complications from surgeries like strictures which are narrowing in the intestines, or diverticulosis, or diagnosing fulminant colitis, like for instance here where it shows like a severely inflamed bowel wall, and sometimes helping determine, along with other symptoms and signs, on whether patients can be managed medically or if they need surgery. Also, like you can see on CAT scans like signs of like of chronic pancreatitis, which can again clarify the underlying diagnosis, or vascular disease, which can sometimes lead to bowel ischemia, which can also, or lack of blood flow into the bowels that can often lead to diarrhea, almost like a heart attack of your intestines. And like I said, for the enterographies, like the CAT scans and the MRs, you can diagnose like small bowel pathology and even tumors. Like I said, there are some hormone secreting tumors called neuroendocrine tumors that can that can lead to diarrhea and can be diagnosed on imaging modalities. And now endoscopy, which is also something that is patients often like, ask about, and sometimes, and often can be necessary. Endoscopy is certainly not needed in every case of diarrhea, but they can help determine the cause or the etiology of diarrhea in about 30% of the cases, especially for chronic diarrhea. The most valuable being the colonoscopy, where not only you have direct visualization of the insides of your colon, but you can also get biopsies, which will lead to a diagnosis. Like for instance here, something called pseudomembranous colitis, which is from the C. difficile, like a bacterial infection, which can be treated with antibiotics. And here more like on the inflammatory colitis, like ulcerative colitis, which is a type of inflammation of the intestines, and even diagnosing colon cancer, which can sometimes present as diarrhea. All right. Now, so moving into the next topic, I'll go over many like causes of diarrhea, and I'll focus a little bit more on some common causes of chronic diarrhea. Okay. Acute diarrhea, which is essentially defined as lasting less than 14 days, are more primarily like infectious in nature. So diarrheas that last less than 14 days and are self-limited and resolve most of the time are secondary to infections. And then in that spectrum, you have like food poisoning, which is essentially not an infection, but it's essentially when you consume foods that are contaminated with a toxin that can cause diarrhea. These are extremely self-limited. Like it usually has like an onset of symptoms within 12 hours of ingestion and will resolve within 24 hours. So, and then more commonly like viruses, which viral and bacterial infections, which will usually last like between 3 to 7 days. Viruses are more limited, like self-limited, usually like resolving within 5 days. And bacterial infections sometimes can linger a little bit longer, but and often are associated with like more systemic symptoms like fevers and body aches. C. difficile, which is a common pathogen following hospitalizations or in immunocompromised patients, and often after taking antibiotics. It's also a cause of acute diarrhea, and obviously parasites. Persistent and chronic diarrhea is anything lasting more than 14 days, but for chronic diarrhea, more than 30 days. It can be persistent, but it can also be diarrhea that comes and goes, like episodic, We often have patients reporting like throughout like 6 months, like a change in bowel habits where every other week or every so often they get diarrhea. So that's like, it's more in the category of like chronic diarrhea. In terms of infections that can be a little bit persistent or recurrent, like C. diff is certainly one of them. And parasites, like the symptoms can sometimes last longer than 14 days. We'll talk a little bit about each one of these in the next slides. So first, diet-related diarrhea. So specific like dietary components may cause or aggravate like diarrhea. One common source of chronic diarrhea is related to diet and consumption of substances that are present in a variety of foods, like and beverages that we routinely consume. Like for example, and in this type of diarrhea, like for example, fructose, which is obviously present in a diverse number of like foods that we consume, and sorbitol, which can be found in some, like in prunes and cherries, peaches, but also in sugar-free gum and candy, because it's like a sweetener, and or soda, or even nutritional bars. So like if you consume any of these in excess, it can lead to diarrhea. Caffeine, and as you can see, it depends on what kind of caffeinated beverages that you consume. Like you can get more caffeine, which often can lead in excess, can also lead to diarrhea, and alcohol consumption. So what happens with any of these is that in excess, they will not be digested and will drag more water into the intestines and lead to more diarrhea. So, but it's a simple fix, is to either cut down on the consumption or avoid it altogether. Okay. In terms of like lactose intolerance, which is extremely common, it's usually self-diagnosed, like patients like see a correlation between consuming dairy and having cramps and diarrhea. But primarily, just to make it clear, it's not a food allergy. It's essentially lacking the enzyme that degrades lactose, which is the sugar in milk products. So either not having enough of the enzyme or having a defective enzyme that doesn't work very well. So there's a huge spectrum of like symptoms. Some people are severely lactose intolerant and others have like mild disease. And then, like I said, like we often advise patients with diarrhea to avoid dairy because infections can lead to a temporary loss of lactase, so the enzyme that breaks down lactose. And if the lactose is not digested, it will go through the intestines, get degraded by bacteria in the colon, and lead to diarrhea. And lactose intolerance is more common in Asians and Blacks. And symptoms, like for most diarrhea illnesses, like bloating, cramping, and diarrhea following consumption of like dairy products. Testing, like I've mentioned, you can do proof of concept at home by avoiding dairy and observing your symptoms. There is a breath test, and there is a blood test that is very seldom like used because we have breath tests to diagnose lactose intolerance. The good thing is that there is no need for medication, and the treatment is really staying away from any dairy products. So usually using milk alternatives like soy, almond, or oat milk, or sometimes digestive enzymes like lactase pills can help. If you take them before you consume dairy products. Another common condition that can lead to chronic diarrhea is celiac disease. Celiac disease is essentially gluten allergy, where gluten essentially is present in wheat, barley, and rye. And what happens in patients with celiac, gluten causes like an inflammatory response in your intestines. And over time, instead of having like this beautiful villi, which help you absorb nutrients in your small intestines, they get flattened, and then you don't absorb as much, like you don't absorb nutrients as well as someone without the celiac. And symptoms, again, like abdominal pain, bloating, diarrhea, weight loss in more severe cases, skin rashes, anemia, bone loss, low energy. A lot of patients report like mental fogginess. The reality is celiac disease has a huge spectrum of symptoms, and a lot of times it's subtle and it goes undiagnosed for many years, until patients are diagnosed with anemia or early onset osteoporosis, like from bone loss, from not absorbing vitamin D and calcium well. The diagnosis is made by blood tests, so we do blood serologies. In some cases, genetic testing can be helpful. But just to make note, the genes associated, the genetic mutations associated with celiac are actually relatively common, especially in Caucasians. And having a positive gene doesn't mean you would have celiac disease, So not everyone who carries the gene will actually develop clinical disease. So primarily the diagnosis is made by blood serologists and biopsies of the small intestine, of the duodenum, which is part of your small intestines, that this is made during an upper endoscopy. In terms of long-term complications from the malabsorption and from the chronic inflammation in your intestines, patients can get anemia, bone loss, from osteoporosis, or in very rare circumstances, like small bowel tumors. The good news is that all of these can be reversed and avoided, by essentially avoiding gluten or going on a gluten-free diet. And often patients with celiac should take supplements like iron, calcium, and vitamin D, and definitely consult with a dietitian, because diet is a major component of the treatment of this condition. I forgot to mention. Now, there is also something called an entity which is not very clear. It's called non-celiac gluten sensitivity, where patients that do not have celiac disease by serologies or biopsies of the intestines do have gluten sensitivity, in the sense that by consuming gluten, they get diarrhea or other symptoms like low energy and mental fogginess. And the treatment is the same. It's avoidance. I always tell patients, if you can sustain a gluten-free diet and you feel better, then obviously there is no objection to that. But it's still a very unclear etiology. So there is a lot of information coming up all the time to clarify this condition. Medications is a very important aspect of diarrhea, because many medications can cause diarrhea. So it's important to carefully review all the medications and supplements in order to make a diagnosis. The mechanism by which some drugs can cause diarrhea is not very well known, but up to 4% of cases of chronic diarrhea are actually due to medications, and more than 700 drugs can be associated with diarrhea. For instance, syrups, they often contain sorbitol, which can cause diarrhea. Some medications can contain magnesium, or supplements with magnesium can cause diarrhea. Some blood pressure medications, anti-inflammatory agents like Motrin, Aleve, Advil, some diabetes medications. So it's always important to consult with your doctor. Antibiotics often can cause diarrhea because it disrupts the normal bacteria in your colon. And so often patients with antibiotics will develop diarrhea, and that sometimes can linger a little bit after an antibiotic course, and also puts you at risk for C. difficile, like I mentioned before. Another condition that sometimes is common, it's patients that use laxatives, abuse laxatives, and obviously that can lead to chronic diarrhea. Another condition that is often missed or misdiagnosed is something called microscopic colitis, which is about 7 to 10% of patients with chronic diarrhea. And up to 10% of patients with IBS are patients with microscopic colitis are misdiagnosed as IBS. So meaning you assume that it's IBS, irritable bowel syndrome, but in fact, there is a problem which is called microscopic colitis. We see it more commonly in women and of older age. Sometimes it can be triggered by medications like antidepressants, like SSRIs, like escitalopram, or proton pump inhibitors like omeprazole and Nexium, and sometimes anti-inflammatory agents like ibuprofen, Aleve. The diagnosis is essentially made by biopsies of the colon. So a colonoscopy is needed for this condition because everything else comes back negative. Like the blood work is normal, the stool tests are negative, and even on a colonoscopy, the lining of the colon looks normal. So it's really a pathological, it's a diagnosis we make under the microscope. And it's important to make because, whether it's triggered by a medication and simply withdrawing the medication will usually resolve the problem. But sometimes you need treatment for that, which is not a lifelong treatment, but something that can quickly reverse and resolve your problem. So this is very commonly overlooked and common problem associated with diarrhea. You read about bowel syndrome. By no means I will go over everything about IBS, but again, I just to mention that it's extremely common and it's a common cause of whether persistent or episodic diarrhea. It's essentially defined by recurrent abdominal pain and diarrhea. Like I said, symptoms again, abdominal pain and diarrhea. There is no diagnostic test for IBS. And it's similar to different from microscopic colitis, which is eventually diagnosed with biopsies of the colon. In IBS, everything is normal. So blood work, stool tests, and colonoscopies and biopsies, everything comes back negative. That doesn't mean there isn't a problem. And there is no cure for IBS, but I always tell my patients that the treatment is lifelong, and that's when it's super important to establish a good relationship with your gastroenterologist and not give up because there are ways that you can improve your situation, whether it's lifestyle modifications, dietary changes, fiber supplements, antispasmodics, sometimes antidepressants. There are many, many ways to treat IBS. So that's one of the conditions that I would say it's super important to have like a gastroenterologist that you can work with in the long run. SIBO, another condition that is commonly asked about like by patients because there is a lot in the media. It's a popular topic, but essentially what it means is like it's a small intestinal bacterial overgrowth, and it means that there is an abnormal increase in the bacterial population of your small intestine, which can often lead to diarrhea. Okay, the symptoms include abdominal pain, bloating, diarrhea. There are risk factors associated with SIBO. It's like a tricky diagnosis because there are usually conditions that will lead to SIBO, like for instance, prior bowel surgery or structural abnormalities like diverticulosis, which are pockets in the bowels, or narrowing like strictures, or fistulas, which are communications between the bowels, or some medical conditions like diabetes, scleroderma, or severe constipation. This can all lead to bacterial overgrowth in your intestines. Chronic PPIs have been question whether they can lead to SIBO because of like the decreased acidity in the stomach and then leading to more bacteria growth in the intestines. The diagnosis primarily, I've personally never done a small bowel aspirate, so we usually use the breath test, which has some limitations, but can be very helpful in diagnosing SIBO. And it's important to diagnose again because there is treatment, whether it's to eliminate the root cause or taking antibiotics for SIBO. Diarrhea after surgery can also be a common problem, especially in gallbladder surgery from malabsorption of bile acids. So when you remove the gallbladder, you still produce bile, which can be secreted directly into the intestines and not being stored in the gallbladder, and then that leads to irritation and of the colon and diarrhea. Or if you have like a resection of like the distal part of your small intestines, that can also cause like bile acid malabsorption and diarrhea. In some types of surgery, you can have increased transit, whether it's a small bowel resection, like removing big segments of your small intestines, or injury to the vagal nerve, where again, then the transit, like your intestinal transit, is accelerated and there is less time for absorption, so leading to diarrhea. Or some surgeries which can lead to small intestinal bacterial overgrowth, like I've mentioned before, and then lead to diarrhea. And then this is like beyond the scope of this webinar, but some diarrhea, chronic diarrhea illnesses can be from other medical conditions, like for instance, like I said, like vascular ischemic bowel disease, where you have blockages of the vessels in your intestines and it can cause chronic diarrhea, or inflammatory bowel disease like Crohn's disease and ulcerative colitis, endocrine problems like thyroid diseases or neuroendocrine tumors, which are tumors that secrete hormones that can lead to diarrhea. Some autonomic neuropathies like diabetes can also alter the motility of the intestines. This I've mentioned before. And cancers, so colon cancer, some small bowel lymphomas, or like I said, hormone producing tumors can all lead to diarrhea. In patients undergoing radiation as well, sometimes the radiation can trigger diarrhea, and it can be a serious complication from the cancer treatment. In terms of treating diarrhea, eliminate the root cause, treat each individual condition. It depends on the diagnosis. I will touch briefly on antibiotics, prebiotics, and probiotics. Bile acid binding agents can be used for patients after gallbladder surgery, and sometimes it will solve the problem, like the diarrhea problem. And in some cases, like in severe cases like of diarrhea, some patients may end up like needing surgery. All right. So let's talk a little bit about antibiotics in acute diarrhea, because a lot of times patients come to the office with the expectation of getting an antibiotic and getting better right away, and that's not always the answer. These studies have actually shown that the benefits of like antibiotics for acute diarrhea, it's only for patients that have recently traveled or in diagnosed like parasitic infections, because treating with antibiotics can sometimes lead to some complications, especially in cases of E. coli, salmonella, or like by using antibiotics, you're prone to having C. difficile. And often antibiotics can lead to functional bowel disease, where like by disrupting the normal flora or microbiota of your intestines, it can lead to more diarrhea, a more protracted course. So again, this is obviously you need a doctor to prescribe an antibiotics, but bear in mind that for acute diarrhea illnesses, antibiotics are not always the answer. And prebiotics and probiotics, so prebiotics are essentially foods that are not digested, and then when broken down by the bacteria in the colon, produce like antibacterial substances that can be beneficial. And probiotics is essentially ingesting live cultures, so live bacteria that can colonize your colon and produce substances that will protect you from digestive problems. So for example, like the health benefits are like probiotics can produce antimicrobial substances. They can activate the immune system. They can improve digestion. And by colonizing the colon with good bacteria, you prevent the bad ones from causing problems. But the truth is that there is not a lot of scientific data for the use of probiotics in acute diarrhea illnesses. It doesn't mean that they don't work. Not everything can be studied or proven scientifically. So sometimes, based on clinical experience, for some patients, it can be beneficial. But definitely it can be helpful for patients that have diarrhea following a course of antibiotics. So probiotics in that case, we often, like after an antibiotic course, we always recommend taking a probiotic for a couple of months. And then finally, how to prevent diarrhea. This is a no-brainer. I mean, we talk about this all the time, especially now in the COVID era. Good hand hygiene, hand washing is extremely important, especially to prevent C. difficile. Storing food properly, and then when traveling, avoid drinking tap water. Do not consume milk products or unpasteurized milk or juices, and then avoid raw and uncooked meats and vegetables and fruits. So all of these is important, like in preventing diarrhea. And vaccination, but that's more for, I'm sorry, I spell. for children. So the rotavirus vaccine is often given to kids. Most important, what I want you to take from this long talk, and I'm sorry about that, is that most acute diarrhea illnesses are self-limited and often antibiotics are not needed. Be aware of like dehydration, because that can be more serious and it can lead to serious complications. And also of the alarm symptoms, like where you shouldn't wait to see a doctor, like I said, bloody stools, fevers, profound weight loss. And then because diarrhea can be a symptom of severe illness. So we're all here to help. We have a wonderful group of gastroenterologists, dietitians, and physician assistants. So we're here to answer any questions and help you through your illness, okay? So without much to finalize, I would like to thank you for participating in this webinar, for your time and attention. And I think we have some time for questions, Steve.
Yeah, thank you, Anna. That was amazing. It's such a broad and complex topic. And I think you did a great job of summarizing the highlights. And we have a few really great questions I wanted to get your thoughts on. So one is pertaining to IBS. You sort of touched upon it. And it's a term that's really thrown around a lot. So what is the difference between having IBS and having diarrhea?
Okay, that's a great question. So IBS, there are different types of IBS. So obviously, I touched upon like IBS diarrhea, where patients have by definition, IBS is when you have chronic abdominal pains with either diarrhea or constipation, or sometimes both. Some people will only have diarrhea, which often, like the cramps and the abdominal pains, often improve with bowel movements. It can be episodic. And most of the time with IBS, what we usually look for are alarm features, right? Like, so for instance, like I said, in irritable bowel syndromes, I always say it's a problem because it affects your quality of life, right? And it's a long-term problem. It's different from like a diarrhea illness, more serious illness, in the sense that often there is no weight loss. There is very little risk for dehydration. Your blood work, all the tests will be normal. Your colonoscopy is normal. The stool tests are normal, meaning there is no clear cause, no clear culprit. It's poorly understood in terms of what leads to IBS diarrhea, but it's it's not something that it's chronic, but different from a diarrhea illness where there is no diagnostic test or no specific treatment. There is no specific medication that will cure your problem. So like I said, it's a long-term treatment that you have to work along with your gastroenterologist in trying to figure out what works for you. I always say the treatment for IBS, it's individualized. Not every person is different. I hope that answers the question.
Yeah, I think that makes sense. Not all IBS is diarrhea, and not all diarrhea is IBS. There's a lot of nuances. And another question that came up in terms of all these terms is, what's the difference between IBS and colitis, and how are they related to diarrhea?
Okay, so colitis is when you actually have, like I said, there's a microscopic colitis, and there's the inflammatory colitis, whether it's caused by Crohn's disease or ulcerative colitis or any other types of medical problems. But colitis is essentially when you have inflammation in the lining of your intestines. So not only visually on the colonoscopy, the colon will look inflamed and abnormal, but also under the microscope. So in IBS, when you look inside your colon, it looks normal, and on the biopsies, it looks normal as well.
Okay. We had a couple of questions come in about microscopic colitis, so including treatment for microscopic colitis. So one is in terms of budesonide. So budesonide is often prescribed for microscopic colitis. So in your experience, how effective is it, and how safe is it? And is it safe for it to be continued for extended periods of time?
Yes, so budesonide, so like for microscopic colitis, one of the most important because it's very commonly associated with taking certain medications. Like I said, especially SSRIs, which are anti-anxiety, antidepressant medications that are commonly used. So that is simply fixed by changing the treatment and removing the medications. But in the cases where we can't pinpoint like the root cause of the microscopic colitis, we use budesonide, which is like a type of steroid, definitely with not the same side effects of like prednisone, because the absorption into the bloodstream is less, so obviously there are always risks associated with chronic steroid use, like in terms of like fluid retention and glucose problems or affecting your bone health. But most of the time the treatment is short term. I would say, like from my experience, like I usually treat patients like within it can be anything from like 2 to 6 months, and as the symptoms get better and you start titrating off the medication, so the dose is decreased over the course of treatment until you eliminate the medication altogether. And often patients like stay well for a very long time, and sometimes indefinitely. It's hard to say, it can always come back. But it's certainly, I've never had a situation where I needed to keep a patient on budesonide for year after year. A lot of times it's very effective, and the treatment is limited to a certain amount of time. What is your experience, Steve?
No, I completely agree. I think it's in general, it's effective, it's safe, and a lot of people are able to taper off it over time. But some people have flares and they need it again down the line, and there's nothing wrong with that. Staying with the theme of microscopic colitis, there were a couple of questions about other treatments in the long run. So is it safe to use things like Imodium chronically? And is it safe to use things like Pepto-Bismol chronically for microscopic colitis?
That's a great question, because, a lot of times that's a very good question, because often I will, when the symptoms are not too severe, I will try like whether it's fiber, like we use a lot of like times like fiber to bulk the stools, in addition to like Imodium once a day or Pepto-Bismol. And sometimes that will do the trick. Yeah, I have no problems with that. If the symptoms are mild, and again, I try to work with my patients and, see what their expectations are. If you want like immediate, like resolution of symptoms, then I would say probably budesonide is the right answer. But if the symptoms are not too severe and, you can compromise and a little bit, then I think it's perfectly fine to try Imodium, Pepto, or even fiber to bulk and bind these stools a little bit.
Let's see, a lot of great questions coming in. One question that I think this is a fantastic question is, can someone have both Crohn's disease and irritable bowel syndrome?
Absolutely. And, that's when a lot of like the testing can be extremely helpful, because we often have patients with Crohn's disease that are doing wonderful, in a sense that you do a colonoscopy, the colon looks great, the biopsies look, no active colitis, nothing severe. And you do blood work and stool tests and everything looks great, but you're still having diarrhea, you're still having symptoms. So there is definitely an overlap. And then obviously, you try, instead of like ramping up the treatment of Crohn's, you would treat that patient as like more like as an IBS patient, as opposed to, increasing the dose of like Crohn's medication. So for sure, a lot of times patients either with ulcerative colitis and Crohn's disease can have their colitis under control and still have symptoms. And that's when we start thinking about IBS on top of their underlying disease.
All right, great. So we're running short on time, so I'll just maybe one more question, and then we'll let you go, Anna. So, what about SIBO? How often can someone be treated with antibiotics for SIBO? Is it a one shot and you're done, or can some people require more than one course of antibiotics?
For sure. And that's a great question. And even more recently, some studies have shown that sometimes you don't even need to repeat the test. You can treat someone with the same antibiotic. Most of the time we use something called Xifaxan or rifaximin. And yes, you can do at least 2 or 3 courses of Xifaxan before, you consider like a failure. One more, you said what was the question again? There was something else in your question that made me.
Can one use repeated courses of antibiotics for SIBO?
Yeah. The other thing that I would like, that I often tell patients, because, in some, and I had a couple of patients where obviously they had surgeries, and there are some anatomical abnormalities that unless you fix them surgically, the patient is kind of like a setup for SIBO, and that can be a tricky situation because you can't keep giving antibiotics forever. But in terms of let's say straightforward SIBO, from whether it's constipation or dysmotility of the intestines, I mean, I wouldn't call that straightforward, but you can treat it with antibiotics, and sometimes patients will get better, but that doesn't mean, and I always tell patients, I try to set up real expectations. That doesn't mean you're going to feel better forever, because my experience is often that symptoms can recur down the line, whether it's a few months or a year later. But in the acute setting, the treatment can be helpful, very helpful for some patients.
All right. Well, Anna, thank you so much for the great talk and for answering all of these questions. I think our time has come to say goodnight, and I'd like to thank everyone for joining us, and we look forward to seeing you for our next webinar. Have a good night, everybody.